Good morning, Crystal. I hope your appointment went well, and it's probably a good idea for you to send a copy of the doctor's report and summary of your visit. So let's go ahead and get started. This week, the topic is external and internal constraints on long-term care. Obviously, the external constraints are things like regulations, public perceptions, public uh, desires and demands of the people who are receiving the care, reimbursement issues, which are a mix of regulatory and others. Um, these are the external. Internal constraints include a lot of different things: budgets, staffing, the availability of staff, um, facilities themselves, what condition they're in. So there are a number of these things. So you're going to be working through them. Um, this um, this week you're going to be doing chapters 9 through 13. So let's go ahead and take a quick look at what those comprise. I'm going to come up here with this and share chapter 9 on the screen here. Starts with part 3 of the text. Chapter 9 is competition, cooperation, and integration. Competition is a funny thing. There are a lot of choices. Competition is like many other things. Finances have driven many of these organizations to consolidate, such that there are chains, of course, of nursing homes. There always have been, but also assisted living, where we combine assisted living, hospice, nursing homes, etc., into a single organization. This is a fairly important issue in terms of competition. Competitive forces, I mean, there are a lot of these things. One hopes that that part of the result of these competitive forces is that they actually lead to better care. However, with the number of people and the constraints on getting in, that may or may not actually be true. So this chapter is good for looking quickly at the environment of long-term care and the changes in financing that have arisen over the years, including Medicare and Medicaid, managed care organizations, and so forth. Competition means that you have people, every one of these homes has a marketing arm that will go out and try to recruit um, um, patients. They'll go into hospitals. They will actually go into hospitals and talk to patients and their families. This applies not just to the long-term care industry, but to the home health industry as well. So there's a lot of competition for getting people in the door. It's not clear what effect competition has on pricing. There are different prices for different facilities, but there are some basic sort of floor pricing. And as you might expect, there is some relationship of getting what you pay for, though not necessarily 100%. When we strive to try to attract patients, there are two things that we can attract them with. One is the lifestyle, and the other is the cost. This especially applies to things like assisted living and so forth that are generally not reimbursed through public methods unless it's through Medicaid and people have gone through the spend down process. Is there a collusion to fix prices? Well, it's that's a sticky question because there are some regulatory issues, and much of what the pricing depends is what the payers, the supporters, Medicare, Medicaid, private insurance, and so forth, are willing to pay. This may not be direct collusion, but it has the same effect as to limit the flexibility that people have in setting prices. They can always raise their prices, and then you get to pay as well, but then finding people to come in is difficult. Long-term care as an industry is something most people don't understand. We'll get to some of those other issues. So let's go look at a different chapter now. Let's just make sure this is being shared. Yes, it is. Okay. External control. This is something that is really there. The external control lies in public control mechanisms such as regulations and who's doing the regulating. Most of these things there are a mix of federal, state, and local regulations that govern these things. It's a complex maze that you, the administrator, need to understand. Not as intimately as your legal help, but you need to understand the effects they have on the ability to operate in a good fashion your organization. A lot of it has to do with quality and payment. Unfortunately, there is a direct relationship between quality and payment. The less you pay someone, the lower quality you can expect in terms of service. This is just a reality. We don't like it, but it's real. So they are related, and so they're actually competing. The regulators always want higher quality, and the funders always want lower payments. And so it's very, very difficult. So we set minimum levels of staffing and cleanliness. Are those always met? Well, my experience is no, depending on what those minima are. So it's a difficult situation. My experience with long-term care involves mostly my father, and he has been in some facilities that have been, at least from my observation, pretty good, and some facilities that I would not regulate and I would not put an enemy into. So it really is a problem. So regulation is there. It's a major role. But there are some certain things here on page 264 that I'd like you really to take a look. This came out of the Omnibus Budget Reconciliation Act of 2002, or I think, or somewhere along in there, or maybe even earlier. There have been several of these. Anyway, a series of rights and responsibilities rights that the patients have, which are similar to the rights that we've discussed in other classes, but really to direct these into a long-term care situation. Freedom from abuse, mistreatment, and neglect, from physical restraint, freedom to choose their own physician, freedom to have access to their medical records, to be treated with dignity, and to the extent they can at least exercise self-determination. The right to the accommodation of their medical, physical, psychological, and social needs, participate in resident and family groups, communicate freely and voice grievances without reprisal, and the right to appropriate discharge and transfer. We've all seen places where those rights are being variably met. And I won't go into a lot of that, but nonetheless, this is what your goal, this is what you need to keep in mind as an administrator, that your patients have, or your clients have, rights. These extend also to specifically named family members that have access to the information and have a right to having that done. This is something that should be set up when a person moves into a facility. There should be a designated person or persons who have access to the information and have certain of those rights. They also have to develop resident assessment process and pre-admission and screening for residents, especially those with mental illness and chronic conditions that may or may not be appropriately addressed. And then if they cannot appropriately address them in the home, they have to not allow them to be there. But this chapter is worth reading. Defining quality is difficult because, of course, it's going to mean different things to different people. And some who know a little bit more about what's going on in the industry and know a little more medically are going to have a different idea of quality than people who are basically ignorant and think that the medical staff knows everything and is always going to do the right thing. How do we measure it? Or who should measure it? You know, we've looked at external measurements. These things have been the source of some abuses in our experience, but that's another issue. Who is going to be looking at your quality? Is it a state regulator? Is it a panel of medical practitioners? Who is going to look at that? The HIPAA, of course, you've studied that over the years. We don't need to go too much into that. But we do have, there are plenty of regulations here. This chapter should be skimmed through quickly, I think, but go through and take a look at and hit highlights here. There are many ideas, but here are there many ideas in this chapter, but specific to long-term care, of course, we have CNAs, we have administrators, and this is starting on page 273, is a good place for you to really study what is going on. In the past, it has we haven't licensed these administrators, but we are now doing so. I don't know about the state of Colorado, whether they actually require it, but I know that this has been a growing trend to people getting certified as long-term care nursing home administrators and so forth. There is little, I think, data to show us that these administrators that are licensed are any better than people who just really want to do a good quality job. But it is part of the world today. And So this section of the book is worth you studying, I think, and maybe including in your um, um, uh, in your summary. Um, some of these things for an administrator, it might be useful to see if you can download a copy of these standards of practice for long-term healthcare administrators. If you can, from the American College of Healthcare Administrators. I've downloaded several documents from them over time that are not this one. But you know, this is something that you will want to understand before going in and be familiar. Um, there are other places as well as you advance in your career that you should be looking for um, really good information on staying current with the trends in long-term care. Chapter 11 is, I think, perhaps one of the more critical things to understand. Money is, unfortunately, something that you as an administrator have to be very cognizant of. Where does it come from? How is it reimbursed? Reimbursement is the driver for long-term care. Reimbursement comes from many sources. Um, and this chapter 11 is really a good one to study in detail. Um, Understanding how it grew up is important. The major change occurred um, the with actually the appearance in the 1960s of Medicare and Medicaid programs. Medicare being an entitlement program, a word I absolutely hate because it has too much baggage. We of course pay into this program. In a way it's pre-insurance that we have been paying into. Plus, um, there are certain parts of our basic Medicare A that cover some aspects of long-term care. Um, and then Medicare B, of course, covers our doctor's expenses, which is also a paid-in insurance. Once you go on to Medicare, you are required these days to have Part B or pay a fine. But it does help with much of medical insurance, and it has helped in many ways keep the cost of private insurance down for many for people who are on Medicare by covering a lot of the expenses as a top line kind of thing. There, Medicare is first, and then your private insurance um, pays the differential. Medicare will cover approximately 80% of the costs, and then you're responsible for the rest. That's why you have private insurance, is basically to cover the rest. But the issue here is that we've gone through a lot of stuff. It's really worth that. But the guts of this chapter starts on 293 with current options. Public, as we talked about, Medicare and Medicaid are the really big boys here in terms of various healthcare services for long term. They're the largest funder and payer for nursing homes, for other long-term care, for home health, for hospice, for all of these things. We have in this house. My wife has a lot of experience in home health. She was a home health PT for about 40 years. And we, of course, went through hospice with my mother-in-law. So we got to experience, my wife got to experience professionally what goes on with these things that are largely paid for by Medicare and Medicaid. And then we have the experience here at home with my mother-in-law. But the Medicare will cover some skilled nursing services. The skilled nursing facility, or SNF, can be paid for. The the skilled care part is paid for, so there's a lot of payment for that. So non-professional staff is not considered skilled care and not covered by Medicare under federal regulations. But this is a part that is really worth studying, because understanding your reimbursement rates and understanding your reimbursement procedures for any sort of long-term care facility is critical to being able to properly manage it. And so it also will inform you for your staffing needs and other things as well. So you also come under the prospective payment materials. I'll let you read that. But home health care, subacute care is covered under the issue of post-acute care, which basically means longer-term recovery, such as rehab, that you have to go through when you are recovering from whatever. Home health care is a part of it as well, and hospice. The other kinds of long-term care, like assisted living, adult daycare, are not covered by Medicare. However, they can come under Medicaid. And again, Medicaid is an interesting mess of these of payment. You have to means test into it, which means you have to be in need. And it was a wonderful program. It is a wonderful program for people who do not have resources and who need care. But it does have a lot of fences built into it that you are about what they'll cover and how they can cover it. The means test issue is important, but also the spend down issue. We really you need to take a look at these and some of the controversies around it. I mean, this book is really honest about the difficulties that we can run into, and how people of means can, and I mean, upper middle class to financially, wealthy folks, have means of hiding their income and protecting their income while taking advantage of these programs. There's been a great deal of effort to limit that with a limited degree of success. But this chapter is important. Then we have private sources, which basically are out of pocket. Long-term care insurance. This is something that you as an administrator really need to understand what long-term care insurance will cover and how it works. But in a nutshell, at some point in your life, you can buy this. Depending on your age, when you actually enroll in long-term care, that will determine the likelihood that you are going to need long-term care, and therefore the rate that you will have to pay for it. So younger people will pay less, older people will pay more, because statistically you're more likely to need it when you're old. There are all sorts of statistics that are very misleading to me about long-term care. going back to our statistics class, I think I mentioned this in the past, going back to our statistics class, we read things like 77% of people will need long-term care or nursing home care sometime in their life. The question that I've asked many times and have never gotten an answer to is what's the average amount of time? Because if you are on Medicare, Medicare will pay for the first 21 days. And if the average is, and the long-term care insurance won't kick in until after Medicare stops paying. So it's sort of, and this is one of their reasons for why their rates are where they are, is that government will pay for that first 21 days. The problem is that they'll also pay part of the next 80 days or 79 days, up to 100 days in an incident. So you're responsible for like $141 a day or something like that for day 20, day 21 through 100, or 22 through 100. And so that's what they'll be paying. So that's what they will be paying as a part of that. So my questions have always been, what is the average length of stay for this 77% of us that are going to need some sort of in-facility care? Never gotten an answer to that, and I haven't been able to find it. The long-term care insurance issue is this whole section is worth reading because it is a rising industry. ARP pushes it. Financial planners push it, but as I said, I can't get answers to what I think are very important questions. And then I'd like you to study this partnership program idea. There are some interesting things coming along. And of course, managed care has come into this, your health maintenance organizations. There's another aspect of this where everything is consolidating. Health care systems are buying buying or building their own long-term care facilities because they can move people out of an expensive acute care hospital into a long-term care facility, and they're cheaper to operate for obvious reasons. They don't have all that multi-billion dollars worth of equipment and sterile operating suites and other things. But there's a lot going on that's changing the nature of long-term care. Chapter 12 is about quality. This is something, again, to look at. Quality requirements are there. There are quality. It's very difficult to define what quality is. Because of course everybody has a different view of that. As I said before, those of us that know something about medicine certainly have a different expectation of quality than people who have no idea. Some of these reports here from the Institute of Medicine, I think you can get them. They should be, since it's a government agency, you should be able to download these things. I would specifically suggest you think about trying to find this Improving the Quality of Long-Term Care report from the IOM and study it, because quality will be one of your points of evaluation by regulators. And they will be looking, regulators come in not to praise you for what you've done, but to find out what you haven't done, unfortunately. So this chapter is worth study as well. Again, there are issues such as quality of life, and again, that depends. Quality of life to a billionaire is very different from quality of life to someone who's um, living on a fixed income. So understanding some of these issues in this chapter are important. Chapter 13, ethical issues, again, something to really be aware of. The guiding moral, ethical vision of an organization is really to provide the best quality care for residents and patients, as well as focusing on the effects that all of these facilities and all of these illnesses and so forth have on their families as well. Having been through that with my mother-in-law, we felt very much that we had a mixed bag of that during our hospice experience. And overall, good, but part of it was the fact that we were here all the time with her. So there's a real difference. Home care is an option. One of the things that doesn't affect you as a long-term care facility administrator, but home care is something that is growing because people are seeing that their loved ones get better care at home. That's one of the reasons we kept my mother-in-law at home. We felt we could provide better care for her. Access is critical. Access is one of the issues in rural locations, and Wyoming is very much a rural state. You probably are aware of a trend going on in rural areas where medical facilities are disappearing. Nursing home facilities, long-term care facilities are disappearing, which means that when someone needs to be placed, they are often placed very, very far from home. So there is some of this. This whole question on the ethics of rationing. Rationing is an emotional term, and rationing has been occurring forever. Rationing is a part of the insurance industry. They decide what they'll pay for. That's rationing. So we have had that as a factor in our healthcare forever. But is it ethical? And where do we draw? Where do we look? Where do we look at the delivery of various kinds of healthcare with a mind to understanding where to what is appropriate and what is not. I mean, clearly it's not ethical to go in and do procedures that a patient doesn't need because you can get reimbursed. That's the obvious one. But what about this question right here on this page? In terms of elective treatments, surgery that is not absolutely essential to preserve life, but will give a person greater independence by eliminating a functional disability. Where do we draw that line? Especially when we have more and more expensive procedures that we get. So this is not there's not a straightforward thing where you can say, well, you just don't do anything that isn't necessary. Well, arguably, it isn't necessary for you to take care of your teeth. You can always get false teeth, right? Well, no. Turns out there's a lot more to it than that, and that there is a direct relationship between healthy teeth and good health. So there are lots and lots of issue. The ethics of spending down. are something that bother me a great deal, because it's a way of stripping assets away from not just the person who has them, but to their family as well, who have been taking care of them for years possibly. So this chapter, of course, is a pretty important one, and the uh, the the whole the concept of beneficence here, which is here, which is the principle of doing good and demonstrating kindness and helping others, um, does conflict to some extent with the autonomy of the patient. And we see this, this is especially the case with patients with various forms of dementia, um, who are physically capable but mentally not capable of not making good decisions. How do we help them not be in a position of making decisions that can harm them? So this comes into protecting um, providers, protecting those that are in their care. Um, the obviously, patient autonomy, it's very common in nursing homes, unfortunately, to medicate patients to keep them from being too much of a burden. And that, I put that in quotes, too much of a burden, because you go into this kind of work because you know you're going to be helping people. If it becomes a burden, maybe you shouldn't be there. But there are people that are more demanding than others. People, especially when people are starting to move toward the dementia part of the spectrum of behavior, and it's easy to over medicate them, to sedate them. And there is no ethical reason for that. It is clearly not ethical, but if you're short staffed and you've got a lot of people that are just really demanding, and there are people who are demanding and not um, dementia patients, it's easy to fall into that trap. It's also illegal, but again, the other ethical question is it ethical not to have sufficient staff to take care of your patients? I think the answer to that is no. However, I don't run these facilities and I don't have budget um, responsibility. So there's a lot of other issues in here that come into the ethics. We've got informed consent, end of life treatment. It is always advisable to have advance directives. Some people will not do that. And the advance directives really state a preference for end of life treatment issues. How much care is going to be thrown, how much technology is going to be thrown at a patient who is failing, to try and keep them alive and functional. Most commonly, you see people who will say, don't do CPR on me, because they are elderly and they don't really, and they, for various reasons, understand that CPR is a very uncomfortable process. So others are, how long do you keep people alive using artificial support such as respirators and parenteral or enteral feeding and that sort of thing? How much effort is to be done? medical profession will want to provide whatever care they think they can give if someone has a chance of recovering. But at some point, a decision has to be there, which is another reason that you want to be sure that if you have a client, a resident in your facility, that there is a medical power of attorney on file to allow someone to make those critical decisions and very difficult decisions. These are something that at this point, we dealt with my mother-in-law, but at this point I'm dealing with my father, and who's 102 and is in not very good shape. And so he has no advance directive and doesn't want to. So we've had, within my family, we have a small enough group of stakeholders here. And believe me, the stakes aren't very much, but we have a small group of stakeholders who communicate on a regular basis about what is being done for him. We are unusual in that we are a fairly unified family group. What we have is pretty much a unified idea of what would actually happen if those decisions have to be made. So these things are part of this ethics thing. Understanding the Patient Self-Determination Act is important. The healthcare providers have to understand everything. We've seen all of these forms and HIPAA forms and disclosure forms and everything else that come in. That's why you're always asked when you go into a hospital if you have a living will or any other advance directive in place. You have a POA. They have a right to have these things, or they have a right not to. Providers have to assist their patients and the other health consumers, residents in long-term care facilities, et cetera, to have these things. Ethics committees are common. The issue of futile care or futility of treatment that occurs when a physician recognizes that treatment will have no benefit on the patient. This can carry over into long-term care as well. So this is something to take a look at and think about the ethical standards. You should probably have, as part of your procedure manuals in any organization, something about ethical standards of treatment that your employees all have signed off on, that they will do that. So that's what I wanted to say about the chapters. I want to go back to this week's work here. The discussion, you can read that. I've already posted once. Your assignment, one, obviously, is to read those chapters and send me a summary. Your assignment two is related to, the impact of all of this kind of cheesy picture of this woman put into a box. But that's really what the impact of constraints is. You're put into a box. So your prompt is about looking at services here and asking these questions. What kind of impact do constraints that are listed here have on this line of service? How important is each? Does it apply to other long-term care lines and other internal constraints that you can identify? So 650 words is approximately 1.5 to 2 pages. So plus your title and reference page. So go ahead and work on that as well. There is, of course, an assessment this week. I know it seems to me you must be having some issues. I know you haven't done any work other than the daily checkpoints. Please try and catch up on last week's work. Yes, it sounds like you're working on your interview assignment. That's great. So I hope your reading is going well and you're taking notes on your chapters as you go. So please try to catch up. If there are problems, please let me know. As I said, go ahead and scan and send us a copy of the doctor's visit, because if there's anything that needs to be addressed here at school, that we'll have the documentation for it. And I hope things have gone well. The code word for today is Lima, L-I-M-A. So I hope to hear from you and see that in an email, and please let me know how things have gone at the doctor. I'm going to cut this off for now. I think this is enough, and we'll pick this up hopefully on Wednesday. I will go ahead and also set an appointment for Wednesday morning.